And the areas of focus, so what do we work on? We work on transparency, interoperability, privacy, analytics. These are all the usuals that we focus on here at eHealth Initiative. But most recently, we've been focused on COVID-19. So if you go to the next slide there, we've been doing a series of COVID-19 webinars. This is just a sampling of some of the things coming up. We've already held about a dozen different webinars and interviews with different experts in the field, and those are all available at eidc.org. But coming up, we've got a great webinar tomorrow on contact tracing and patient matching. Love to have you join us there. Next week, we're going to be talking about the COVID-19 pandemic influencing consumer health behavior. And I know all of our behaviors changed quite a bit, so that'll be an interesting conversation. We're going to speak next week with Dr. Patrick James, head of Quest Diagnostics, clinical officer, and hear all about testing and what that's going to look like in helping people get back to work. And then on the 11th, we're going to be talking about when the curve flattens, fingers crossed, and what's going to happen next for healthcare and COVID-19. So would love to have you join us for those. If there's a topic that we haven't covered and you would like us to cover it, go ahead and shoot Amy an email. You see her email there, and we'd love to, again, get you engaged. Or if there's an executive or somebody you're dying to have a conversation with, like Joe or somebody else there in the field, just let us know. Next slide. So Joe, I'm really excited to have Joe here today. Joe's the Vice President of Government and Regulatory Affairs at athenahealth. And as he just mentioned there, he was barely at athenahealth when the pandemic broke out. But prior to athenahealth, he was at McKesson, and he was the Vice President of Federal Government Affairs there. He's been in the field with public affairs and healthcare for over 2 decades. And has done a lot of work also with the Democratic National Convention. He was a VP at Weber Shandwick, has done, I mean, just an incredible background. You've probably read his quotes in the New York Times or Wall Street Journal, just a wealth of information. And we're glad to have you here today. Thanks for joining us.
Thanks for having me. I appreciate it.
And glad that you're learning your multiplication table. So tell us, so you just came into athenahealth and the pandemic broke out, and just kind of tell us what that was like.
Well, as I say, it was kind of an extraordinary personal and professional experience because, the first week I was there, we had this decision, difficult decision, but I think the right decision by our executive leadership team to encourage our employees to work from home. And thinking about our customers and our patients, that we're a very customer and patient-centered organization. And so we were very concerned about what the impact this pandemic would have on those folks. And while at the same time, ONC dropped the information blocking rule, the final rule, in our lap. And so it was kind of an intense period of time for our team to really dive into that rule and understand how it had changed from the proposed rule. And so it was a very busy time at professionally at a time of both professional and personal kind of upheaval as well.
Yeah. So what did you learn? I mean, so how is athenahealth, supporting providers, and what are they doing right now during COVID-19, especially for folks who might not know exactly how Athena fits into this?
Sure. So at Athena, we're a cloud-based technology provider that supports over 160,000 networked connected physicians on our AthenaNet. We're a little different than some other health IT vendors in the sense that we really believe in the cloud-based kind of solution and operating model. So that's a little bit different. It has some nuances to it. But really, we are a very sort of physician provider-centric organization and patient-centric organization. So the first thing, obviously, we wanted to do is make sure we take care of our people. And so, as I say, we put in place the right kind of work-from-home strategy and tried to think about how to do that, how to deal with some employees who are essential and had to be at a company location. That was kind of first and foremost for our executive team. And so we encouraged folks to work from home, and in fact, ultimately sent everybody home, except for a handful of essential employees in our data centers. And then we really started to think about the impact of COVID-19 on our provider customers. And so we had a lot of aggressive outreach to those customers to understand. And it was an evolution, frankly, because at the beginning, I'm not sure that all of those customers knew exactly what the impact would be on them. And so we tried to work with them in a kind of iterative process over the last couple of months to provide them with the resources and the technology. One of the things our team did in particular is we tried to make, as all of these regulatory changes were coming fast and furious, whether it was telehealth or some of the bailout money, some of the Paycheck Protection Program and other things like that, we tried to make sure we were making that resource available to all of our provider customers so that they knew what government programs were being put out the door in order for them to take advantage of those programs and support their practice. So that was really
I think
something.
a lot of the small practices took advantage of the PPP.
I don't know PPP specifically. I don't have the numbers on what percentage of our practices took advantage of it, but I know that a lot of folks did. Obviously, the program was oversubscribed pretty quickly, and there's been some controversy around that as to who got support. But I think generally, I think the feedback we got from our customers was that they appreciated our efforts to try to make those programs available to them and to provide some analysis of those programs as to whether or not they might apply for those programs. And my sense is that a lot of people at least tried to take advantage of them. Yeah.
Yeah. I mean, as a company that applied for PPP and eventually got it, it wasn't really clear initially. I wouldn't have thought as a small practice that was something I could reach out and try to get. So it wasn't really clear initially who would be able to or eligible for that. So that's great. You were giving them support on those types of things.
Yeah, there were obviously also the Provider Relief Fund and the Advanced Accelerated Payments. So there were a number of programs that were really coming out, and they were all kind of coming out all at the same time, frankly. Yeah. And credit to the government for moving quickly with respect to that once the pandemic became the sort of severity of the pandemic became clear. There was a lot of work that was happening very quickly in some bipartisan ways there early on, particularly with the CARES Act and other things. And our job was to try to make sure our provider customers were aware of that and understood, and our partners and understood how they might benefit from it or how those programs could help them.
So you mentioned the large number of different clients and companies that you work with. What's kind of some of the demographics? Are they smaller medical groups? Are they primary care?
Yeah, it really runs the gamut. So we're primarily an ambulatory physician practices. So it goes from the very smallest physician practice all the way up to a large, multi-specialty practice. It really runs the gamut. But we don't. Athena at one point had some major hospital customers. We're much more in the sort of ambulatory space at this point.
Okay. Well, as someone who goes to a doctor who uses Athena, I was really impressed how quickly they transitioned to telehealth. And can you talk a little bit about telehealth and Athena Health and kind of how you helped organizations make that transition?
Yeah, I think it's been really important. I think, we tend to think of ourselves as a technology company that works in the healthcare space. Mm-hmm. And so as a technology company, looking at interconnectivity and using kind of technology to bridge the gap when folks are not able to go to their physician office, we saw as kind of something natural that we could help our providers do. And so we did a lot of things with our technology to make telehealth possible, including rewriting lots of rules and how to think about processing claims and all of the stuff on the back end to make sure that as they were doing telehealth visits, those telehealth visits were scheduled appropriately and they were going to get reimbursed for them. And there was a lot of kind of reworking some of the engineering to make sure that all worked within the normal workflow. Our sort of approach at Athena has always been, we have the sort of catchphrase that we use, which is let doctors be doctors. Mm-hmm. And what we try to do is provide our customers, our provider partners with the technology that they need to be able to do all the administrative things in their office so that they can spend their time with patients, right? And so when it comes to a telehealth visit, we want to have the same approach, right? We want to make sure that we're providing them with whatever technology solutions they need in order for them to be spending their time treating the patient and for our technology solutions to be helping them to manage all the administrative stuff on the back end. So it's very similar to our kind of overall philosophical approach, but there's a lot of reworking of some of the engineering and rewriting of some of the rules in order to make all of that work in pretty quick real time.
What were some of the bumps as clinicians made that transition and have they overcome them?
Yeah, I think largely they have. I mean, we have seen a significant uptick in telehealth visits. I think when we looked across our network of 160,000 providers, it's hard to say what exactly is pre-COVID, but if you look back to mid-March, there were about 34,000 telehealth visits a week. And by mid-April, that number was 680,000 telehealth.
Wow.
So, and that's just our network, obviously, so it's limited to that sample size, but that's a 20x increase in terms of telehealth visits. And if you think about it, just, because there's a pandemic on doesn't mean that other folks who have acute conditions don't need healthcare. And so one of the things we were focused on was not only how do we make sure that our providers can continue doing what they need to do, but also thinking about the patients that need, acute healthcare during that period of time, right? That need to see their physician or need to consult with a mental health professional or whatever. My family ourselves, we had a telehealth visit for the first time ever during this crisis, and it was great. We were very satisfied with it, and so I think there, and that was something, frankly, that we didn't really want to put off, right? So we were, quite happy that we were able to do it via telehealth with our clinician at that point in time. So I think largely based on that uptick that we've seen, I think folks have overcome the hurdles. I'm sure I'm sort of underestimating the amount of work that some of our product people had to put in and some of the providers had to put in order to stand up those services. But overall, I think there's a real commitment by these providers to make sure that their patients have access to healthcare, frankly. And if it has to be via telehealth during this period of time because of the stay-at-home orders, so be it. We'll figure out how to do it.
And it seems like it's really taken, like you said in the example you gave with your son, or that, people were kind of forced into it initially, but, it's not as bad as people think, and people actually seem to really like it.
Yeah, not to belabor the one anecdote, but in our instance, it was an example of a specialist giving us some test results and explaining some test results to us. And so I actually left that telehealth encounter just personally thinking to myself, I don't know why I would ever do that in the office, right? Like, right. It was kind of one of these things where they were explaining the test results to us. There was no physical exam or anything else. Right. And my wife and I were able to be there together, whereas if it was in the normal period of time, we would have had to try to schedule that so that we could both get out of work at the same time and be there in order to do it. And we were able to do it via Zoom and have a really good, robust discussion with actually two of our clinicians who are in two different locations, who are both talking about, kind of those test results and that care plan. So I walked away from it thinking, wow, that was really cool. And I'm not sure I would ever do that differently. I would, I don't miss the hour drive, the trying to park, the sitting in the waiting room, what probably would have been a 3-hour encounter or a 2.5-hour encounter had we done it in the office turned into a, 35-minute encounter via Zoom. So certainly much more efficient for us and left me very happy as a family member of the patient.
Yeah. And initially, I think there were a lot of concerns about reimbursement from clinicians, and it seems like that's caught up a little bit. What are your thoughts in terms of reimbursement with the telehealth piece? And I think a lot of people are hoping it will stay, but kind of what's your thought about where that's going to go?
Yeah, hard to predict. Certainly put us in the camp of hoping that a lot of these changes will stay. I think that as you think about, maybe this being a tipping point for telehealth, where when that reimbursement barrier was taken away, providers and patients really flocked to telehealth. Now, obviously, some of that's by necessity because of the stay-at-home orders and so forth. Right. But I think my sense is that people had a pretty positive experience with it. And for those interactions with clinicians that don't require a physical examination, I certainly think that once people get a taste for the efficiency of it, you're going to start to see lots of folks feel the way I did, which is to say, yeah, I'd never want to do that in an office again when I could do it via video conference or audio. So I give a lot of credit to Seema Verma at CMS for the changes that they made really quickly. Probably every one of us would have liked it to be a little bit more quickly, but generally I think they moved pretty quickly to really take those regulatory burdens down and increase reimbursement where appropriate. They went to audio only at some point. Those are all really important changes. And, I think a lot of those should be made permanent as we think about this going forward. And, I certainly hope that will be the case.
What about outside of the government, other third parties, commercial, some of the larger health plans? Does it?
Some of those commercial health plans were even ahead of CMS making some of those changes. So I think that's obviously a very good trend as well. And I think there's obviously this is a crisis. And I think that sometimes in a crisis, you do kind of overcome some of those parochial barriers that have always existed to a more efficient, more modern way of doing things. And I think this crisis might have been just the sort of impetus to get over that hump. And I certainly hope that as commercial payers and CMS considers reimbursement and what treatments or what interactions are appropriate via telehealth, I think that they will realize that there's probably a lot of efficiency to be had there.
Can you just clarify a little bit for folks the role that Athena plays in terms of the provision of telehealth? So you're an EHR vendor technology company. Do you actually provide the telehealth services yourself, or are there specific companies that you contract with, or how does that work?
Yeah, so we're involved in it. We have partners who provide a telehealth solution through our marketplace, but we also we do a lot of the work to make sure that to sort of boil it down, when there's a clinical interaction, all of the work that needs to be done associated, all the administrative work that needs to be done associated with that clinical interaction, we're sort of handling for our providers. So that would include scheduling, that would include, prior authorization if necessary, that would include, claims and billing, processing the claim on the back end and making sure that the provider gets reimbursed for it. So in a telehealth environment, that's obviously different than an in-office environment, and obviously doing the EHR and recording, that clinical interaction. So in a telehealth visit, there were some rules that need to be rewritten in order to sort of make sure that all of those administrative things could still happen in the context of a telehealth visit as opposed to an in-office face-to-face visit.
So it's kind of a seamless process.
Reacting to all of the reimbursement changes that were being made so that those claims were being processed accurately, right?
Okay.
Based on reimbursement rules.
So the whole kind of back end and making sure everything gets processed and connected.
That's right.
What do you think? So do you think this has been more expensive for clinicians kind of making this transition in terms of their spending on technology? Do you think, what impact has COVID-19 had on that?
I think it's hard to tell what the overall impact on spending for clinicians has been. I'm not, I don't think that these telehealth solutions are necessarily all that costly, right? We're talking on one right now that's largely free, right? So I think when you start to relax the rules and you think about what the regulatory barriers are, you allow for more entrepreneurial solutions like Zoom, like FaceTime, some of these other things. When you could do audio only, obviously audio only doesn't require a huge technological lift, right? I really think it was a reimbursement barrier to telehealth, not so much a technology barrier. I think the technology's probably always been there and certainly could have been there at a relatively low cost compared to, some of the other changes. So I think the reimbursement really was the driver here, that was the barrier that was in the way.
It seems like there's kind of been all this growth, not just around telehealth, but different digital health tools and remote monitoring. There's talk about that right now. Do you see more remote monitoring going on right now with clinicians, or is it primarily the telehealth piece, or people trying to fit in those other digital apps and pieces?
Yeah, I certainly think there's probably, I don't have the numbers on it, but there's probably more remote monitoring going on. I mean, if you think about the example I sort of think about is, right, everywhere you go. I mean, I went to my eye doctor the other day and they took my temperature outside just to make sure that I was not, that I was healthy enough to go in for that visit. So I think that really, I would go back to 21st century cures. I think the conversation that happened leading up to 21st century cures about how to regulate health IT solutions was really an important conversation. Certainly probably in my career will stand out as one of the more significant things I was involved in. And that is, as we think about the sort of spectrum of risk associated with different health IT products and certain solutions, which ones of those should be regulated and which ones of those should be relatively deregulated. And I think by deregulating several categories, including EHRs and some clinical decision support and other things, I think the Congress really set us on a path for a pretty innovative period of, development of new apps, including mobile apps, and also including, a lot of the remote monitoring potentially. I mean, I think they've sort of opened the floodgates by saying we're not going to regulate all of those things as a medical device. And I really think that's a significant policy change that we'll look back on, 10 or 15 years from now and say, boy, that was a big moment.
So, I mean, one of the things I've kind of noticed around this whole period is all the discussions around interoperability and how we wouldn't be able to handle a period like this. And it seems like the adoption of telehealth has gone pretty quickly, and I wouldn't say, effortlessly, but it's moved quickly.
Yeah.
And interoperability hasn't necessarily been an issue with telehealth or adopting telehealth. Are there areas that COVID-19 has really shown a light on in terms of interoperability being a major issue or problem?
I'm not sure that COVID has had a sort of impact on the interoperability discussion per se. I think when you think about a lot of the telehealth visits, and I don't have the numbers in front of me here, but I would imagine that a lot of those are folks going to providers that they previously had a relationship with and doing a telehealth visit instead of an in-office visit in order to maintain whatever healthcare program, that they were involved in with their clinician. I don't know that necessarily there were a lot of impacts on kind of interoperability during this period. I thought it was quite interesting, though. I will say that ONC did not hesitate to put out the final rule related to information blocking, and then subsequently the proposed rule with respect to the OIG civil monetary penalties.
Yeah.
They did delay some of the deadlines on the information blocking rule, but I would say fairly modestly. So, my message to our executives is, very clear the government is absolutely committed to implementing the information blocking rule. We think that's really important. And I think we're looking hard at the deadlines and working with our providers to make sure we can meet those deadlines. And full speed ahead. I certainly think if one was being cynical, one could have taken the opportunity during the COVID pandemic to try to make an argument that all these things should have been, delayed or suspended or whatever. And I think the fact that the government moved forward with them really shows a pretty deep commitment to, fulfilling the statutory mandate of 21st century cures.
So your perspective on the delay is that you're going to just move ahead and you don't see a need for a delay right now?
I think the delay was pretty modest, and I think we're focused on implementation with our provider customers.
In terms of documentation of the telehealth visit, how does that happen with athenahealth? Is it digitally captured somehow?
Yeah, it's all
connected.
Yeah, I'm not an expert exactly on the engineering, but it is certainly, the telehealth visit is captured similar to an in-office visit, right? So we're using our cloud-based EHR to capture that visit, and then using other technology in order to process the claim for reimbursement.
Okay, great. What about kind of new data and sharing requirements? So there's been a lot of discussion around sharing more information around test results and COVID-19, and kind of what's your thought on that and your perspective?
Well, this is sort of my personal perspective, not necessarily the Athena perspective on this, but I've had a lot of conversations with folks in the industry and outside of the industry about contact tracing, and folks who have expressed concern about privacy issues, and even some folks outside the healthcare industry, laymen, if you will, who've said, "Oh my gosh, that feels like the brave new world." And the analogy I always use with them is I say, when you get the alert on your phone that tells you there's a tornado in your area and that you should seek cover, does anybody object to their privacy having been violated because somehow, somewhere, somebody figured out that you're in the exact area based on the location services on your iPhone being turned on, that a tornado is about to touch down? I could say personally for me, it's never bothered me when I get those alerts, right? I think it's a real value add. And I think you could look at lots of other analogies in our lives where folks have traded some relative privacy protections in favor of convenience, right? I mean, there's certainly, if you look at mobile banking and some of the other things in life, there's lots of examples. I mean, people are swabbing their mouth for DNA and sending it into 23andMe to find out where their great-grandfather came from. Right. So I think there's plenty of examples when you talk about privacy, not so much in the abstract, but in terms of the use case benefit. I think people would say, if you talk about the use case benefit of, we could tell you when there's a tornado about to touch down in your backyard and tell you to go to your basement, people would say, oh yeah, I'm okay with that.
Right.
And by the way, if they're not, they could turn location services off on their phone and sort of opt out of that system. So it's entirely sort of voluntary in that sense.
Let me follow up. We've got a couple of follow-up questions here from the audience. Let me just try to get through these really quickly. In terms of the statistics that you cited, Joe, around telehealth, does that include email and phone calls? I don't know if that makes sense to you. Do you separate that into, so person-to-person visits? Do you guys, so there's a whole discussion around reimbursement for, the video calls and then those done without the video, just health calls. Have you guys looked at that at all?
I did not have that data broken down by video and audio versus audio only.
Okay.
But those would all be either video and audio or audio. I don't think that would include email communication. But
I think some people are including the email and the phone calls as telehealth visits, and they're not necessarily.
Well, certainly if it was an audio only consultation that was reimbursed under the changed CMS rules that now allow for audio only,
yeah,
probably included in our numbers. I didn't break it down that way though.
Okay. Sorry for the specificity.
No, these are great.
Regarding the telehealth reimbursement restrictions being temporarily lifted, do you think our experience with the COVID surge in telehealth confirms or disproves the anticipated risks that these restrictions were designed to avoid? That's an interesting question.
Yeah, so it a little bit depends on what the anticipated risks that these restrictions were designed to avoid are. I think that certainly there was a concern about additive, arguably unnecessary interactions with your clinician via some kind of telehealth methodology, whether video or audio only, that would be, significantly additive to the cost of healthcare. And certainly I think that was a concern that OMB included in their various models that they've where they're thinking on this, that they've sort of thought about over the years. I don't buy into that personally a lot. The discussion that I had with my via telehealth about my son's test results, I would not then next week go into the office and ask them to read those test results and explain them to me all over again. That was an additive service. It was a replacement service. Now I realize that's anecdotal, but I'm not, my personal opinion is that I think that we probably ought to think about a sort of comprehensive, ecosystem of care where you're getting the care you need, and particularly in a value-based model, and we're less focused on whether that care is in person or via telehealth, right? Down the road. I think that's probably the right way to think about it. And if there's a interaction with your clinician that needs to happen in person for obvious physical examination reasons, that's perfectly appropriate. Just like sometimes you actually need to go to the bank, right? And in person. Sometimes, you could do all that from your phone. Sometimes you could do it over the phone. Sometimes you could do it on the web. I mean, I think, my personal sort of view is, I think we need to think about healthcare as something that we do rather than a place that we go. Okay. And I think that our reimbursement system right now is, a little bit lagging the way folks think about kind of how they do things in their lives, right? And so we reimburse based on where you go. And this gets into the whole, sort of site neutral payments and all these other kind of debates, but there's a lot of debates happening about why do we distinguish between, a reimbursement, not for the service, but instead based upon the setting of care or the setting of the service. And I know that's kind of provocative, and it's certainly my
great. I love that. A thing that we do rather than a place that we go. That's a great, I like that.
And one of the analogies I often use is I'll say, I'm a lawyer by background, right? So if I call up my lawyer and I spend an hour on the phone talking with him, he bills me for an hour.
Right.
If I go into his office and sit in his office with him where he has all kinds of overhead and everything else, he still bills me the same amount for the same hour. It isn't, and it's not a perfect analogy. I understand that, but this idea that we've built this reimbursement system around sort of settings of care as opposed to providing the best care through whatever means, almost with an agnostic view as to what those means are, and letting the providers figure out the best methodology that works for them, I think is a better regulatory framework.
Yeah, that's really interesting. So we've gotten the question about security. How is athenahealth protecting patient security? And you're not a technical expert and a privacy expert, but kind of what's the perspective, Athena's perspective on privacy and security around their telemedicine?
Well, so I certainly think that if you think about a much more connected ecosystem of healthcare, certainly you can't have that conversation without talking about privacy.
Right.
I think in the current pandemic, obviously HIPAA applies, and there's been a little bit of enforcement discretion that's come out from OIG and others, or Office of Civil Rights rather, talking about how they're going to enforce some of the HIPAA provisions, particularly with respect to telehealth. So I think that's been a positive thing that has allowed telehealth to thrive during this period.
Yeah.
But I think there needs to be a wholesale review of HIPAA. It's a 25-year-old law. It was written at a time when we didn't have smartphones and the internet was, very nascent. And we're now obviously in a much different world, right? I'm gonna Zoom later tonight with my 80-year-old father, right? So that's how far we've come in terms of, technological advancement and ease of use for lots of folks. And I realize that's not universal, and there's still bandwidth issues, and lots of folks who don't have access to video on their smartphone or on their telephone. But I think that it's probably time for the government to look at HIPAA and think about kind of new technologies and new value-based care models and think about how we maybe rethink that sort of paradigm with respect to privacy. Privacy in healthcare is obviously always going to be extremely important, but I certainly think it's reasonable to look at a law that's 25 years old and say, probably need to update that to account for modern technology.
Yeah. Well, I have to put a plug in for eHealth Initiative and CDT. We're running the Robert Wood Johnson Foundation grant right now, developing a consumer framework for healthcare privacy. So we're hoping, and later this year, we're going to come out with some of our recommendations. So hopefully that will help shed some light on it. But I love your perspective in terms of HIPAA being outdated, which I think we all can agree. What do you think is the timeline in terms of looking at new privacy rules or national legislation? Or I'm always kind of curious what people think, if it's even possible here.
Yeah, I certainly think that in the context of GDPR and CCPA in California, I think there's an increasing push. I also think there's a desire, sometimes being driven by politics, around consumer data generally, and thinking about consumer data privacy generally, and what the consumer rights ought to be with respect to data that's, consumer data captured by third-party companies, and then how that data can be used. So I certainly think that the sort of modernization of HIPAA, if you will, could be worked into that broader conversation about, what's appropriate and what's not. I mean, I think in HIPAA, or within the healthcare context of data privacy, there's some different issues where healthcare data ought to be treated a little bit differently than consumer data.
Right.
And in particular, I think that, you ought to think about, if you're doing something that's very obviously designed to benefit the patient, that ought to be, sort of reflected in the framework, right? I mean, there are certainly instances, I bet lots of folks on the phone could think of instances where a healthcare company or clearinghouse or whatever could do something really interesting with data that would be very beneficial to the patient in particular, and or the healthcare system more generally. But a business associate agreement prevents them from doing that, or the overlying covered entity has strictly prohibited that. I mean, part of the tension here that I think is pretty interesting is that you have HIPAA as a law, and this is obviously an oversimplification, but HIPAA as a law that says you can only share data if X, Y, Z.
Right.
And then we have 21st Century Cures information blocking that says you have to share data except for in these exceptions. Right. And that's a little bit of a tension that I think probably policymakers would be wise to think about and try to reconcile a bit.
Right. I mean, one of the things we always have discussions about is we're focused on non-HIPAA data not covered by HIPAA. I think it's like health-ish data. Yeah. And one of the things I think, that's been discussed, is this a role for Congress, or is this something the private sector should really kind of take the lead on to ensure that there's strong privacy protections for the data that falls outside of HIPAA? I'm just curious on your perspective.
For data that falls outside of HIPAA, well, I think certainly how to think about, I mean, I think that's also true, as you think about HIPAA, it narrowed the data covered by HIPAA to a particular set, right? And that data, the healthcare data broadly, has expanded well beyond that. So I certainly think that's a conversation that ought to be part of this, I think, more global updating of HIPAA discussion.
Right.
But I think that, I think the bottom line is that HIPAA probably needs to be updated. It needs to be reconciled with other, I saw somebody in the chat just mentioned the PHI security requirements in high tech. That's absolutely fair point. I think a lot of these things need to be reconciled with one another. We certainly need to think about state laws and how the federal law, interacts with state laws. That's a topic that ought to be part of that discussion. I don't necessarily pretend to have all the answers as to what a modern healthcare privacy regulatory framework should look like. And I'm sure there are probably lots of ideas on this call. But I think it's time for the discussion.
Yeah. I mean, I hope that we can have the discussion. It's been really interesting, particularly with the contact tracing discussion going on right now, and HIPAA's kind of taken a back seat, although there are all these issues coming to the forefront, I think.
Yeah, I think that's right.
Yeah, it's an interesting time, definitely.
And the discussion on privacy with respect to consumers, and so in the case of healthcare patients,
Right.
often centers on the patient ought to be able to control, access to their data. And that's perfectly reasonable. I think that sometimes that gets translated into the patient ought to be able to prevent their data from moving around freely.
Yeah.
And I think that that's kind of mischaracterizes, in my view, what's the sort of right approach to it, which is if our assumption is that the patient ought to be able to control their data, it's equally true that a patient who wants a much more connected healthcare system working on their behalf
Right.
ought to be able to have their data moving around freely.
Right.
And right now, that can sometimes not be the case.
Mm-hmm.
So a patient who might want to access, or, one of the best examples is, HIPAA has a right to, I have the right to collect my data from my healthcare provider. So if I go to my doctor's office and say, I want my record, they have to give it to me, right? And we all know that that's not necessarily seamless always. But in the financial services world, I could say to my bank, not only do I want my, statement from you, and I have a right to have my statement from you, but I want you to live feed my transaction activity into my Quickens app so that I can track my spending from any different accounts and do my taxes more effectively at the end of the year or whatever, right? I want to be able to look at, Bank of America, Fidelity, and, my mortgage or whatever, all in one app as opposed to having to log into all three. And I could direct them to live feed that. Now, there's no law that requires them to do that. It's the market that's required them to do that. These banks have realized if they don't make that service available, people won't bank with them, right? So that's a bit of the tension you were kind of hitting at earlier, which is where is it important that we have regulation and where is it important that we have sort of market forces at work? And I think with respect to regulation, I think it's really important that the regulations are practical. So telling me that I can drive around to every provider who's ever provided service to me or demand that they send me some relatively unworkable electronic copy of my health record that, then takes hours and hours to try to integrate into one single source. Yeah, that's a patient right, I suppose. But
Right.
practically,
Right.
I don't know, right? How serious that really is.
Well, I think that also gets you just into the interoperability in general.
That's right.
What's actually practical, what's needed, to ensure there's quality care, and what's kind of nice to have. So
that's right. And I think we're sort of on this continuum, right? I mean, the HITECH Act is designed to move folks from paper records to, electronic records. I think that 21st Century Cures and the 21st Century Cures says we're going to deregulate a lot of low-risk software so we can have an entrepreneurial environment.
Right.
Where folks are developing, a race to the best app, if you will.
Right.
And then the info blocking rule says, yeah, you can't hoard data for commercial competitive reasons. It's got to be reasonable. There's got to be reasonable sharing of data and reasonable interconnectivity across systems, right?
Speaking of, what's your perspective on the information blocking rule and just information blocking in general? Do you see it happening a lot, or what's your thought?
I don't know that I could say how much I see it happening, but I certainly think that, having been involved in advocating for the original 21st Century Cures language, I think that it's really important that we break the sort of barrier of I could use competitive and or convenience excuses not to share information. Mm-hmm. I think the exceptions that ONC has carved out in the information blocking rule do a good job of kind of threading that needle.
Yeah.
Including the new one that they added from the proposed rule to the final rule. I also think that what I like about the information blocking rule in particular is it's technology agnostic, right? So it sort of speaks to the outcome, the what, if you will, and not the how, right? You can't, information has to flow, and they've got some prescriptive elements in there as to various standards that have to be used and so forth, but it's very open to different business models, different revenue plans, for example, and how that works, how folks can charge for connectivity reasonably. I think it's a very market-driven set of regulations that will set guardrails that information has to be shared and that you can't block it, but allow the private sector to really figure out within those guardrails how best and how to do that really efficiently, and they'll compete like heck against one another, and the best technology will win, right, at the end of the day, as opposed to saying we're going to be very prescriptive about exactly how you have to do it, and have the result be that 3 years from now, we're talking about how the information blocking rule is outdated because after all, technology has just, leapt over whatever that previous iteration was.
So what do you think, I mean, in your perspective, is kind of the greatest barrier to providers sharing information? Is it a regulation? Is it a technical issue? Is it just kind of market? There's not an incentive there?
Yeah, I certainly don't think it's technology, right? I'm a firm believer that, and the engineers will probably yell at me for this, but I really don't believe there's a technology barrier. That's not to say there isn't technology work to be done.
Right.
But I don't think that's a technology barrier. When you think about every other aspect of our lives, every other industry has overcome this problem, right?
Yeah.
So I think that to some degree, there's a privacy challenge, right? The need to treat healthcare data differently requires extra work and frankly, some cultural fear that's associated with that has to be kind of overcome. People have to get comfortable in an environment where their information is flowing a little more freely and realize, hey, there's not some great harm coming from this. So I'm actually okay with a more open system.
Yeah.
I do think a big part of it is business incentives.
Okay.
I do think that a big part of it is folks thinking about, we have data, we can use that data for competitive purposes to either keep all of our patients within a closed system or to discourage patients from getting care elsewhere outside of our system. I think that's at sort of the worst end of it. Even at the better end of it, I think it's just, what is our incentive to sink money into APIs, for example, that allow for free flow of information when we don't benefit from that financially?
Right, right.
So if we've got limited engineering resources, why do we put them on that, right? And I do think that, the information blocking rule goes a long way to sort of eliminate some of those barriers and say, it's not a question of whether that's the best ROI for you. You now have to do it as a matter of law. You have to allow for information sharing. And I think that's really important because I certainly understand, I'm a free market guy, right? I understand the free market why you wouldn't say, wait a minute, we should make it very easy for all of our customers to shop elsewhere, right?
Right.
I get that. I understand the misaligned incentive there. But at the end of the day, we have to be thinking about sort of what's in the best interests of patients and the healthcare system. And a much more interconnected ecosystem is clearly in their best interest. And so how do we remove those barriers where we can?
In terms of this pandemic, do you think that our data sharing capabilities as a country are set up in the right way to kind of gather information about the state of, where we are in treatment and diagnosis and kind of where we are in this pandemic cycle? Or do you think it's kind of to our detriment that we're all kind of decentralized and on working with different vendors? I mean, what's your thought?
I think that the current crisis is shining a bit of a light on our fragmented system, right? And I think that we are starting to realize how relatively disconnected the healthcare system can be at times and how there's, a lot more work we need to do. I hope that will be a good thing, that we will sort of redouble our efforts to think about how to make the system much more of an ecosystem as opposed to lots of different unconnected networks. And I think that's a really positive benefit that could come out of this, and I certainly hope will come out of this. Telehealth's a piece of that, right? Interoperability is a piece of that. But really thinking through, in the value-based care context, how do we think about healthcare much more about the outcomes rather than whatever the pathways are to get there?
Yeah, yeah. I mean, it's really been amazing, I think, how telehealth has really helped us during this, difficult time. I mean, the number of people that have been able to access care that weren't able to get care before is just tremendous.
Yeah, that's right. I think, what do you do if you can't access care? You have to do telehealth. And so that's, again, kudos to the government for stepping in and for third-party payers and getting rid of those barriers. But the question is, what happened, 9 months ago with somebody who had a hard time getting care?
Right.
We didn't have lots of good solutions for them, right? Whether it was rural areas or people who are homebound or whatever. So I think that, there's lots of talk in the media these days about sort of the new normal, right?
Yeah.
We're not going back to the way life was before. We're going to a new way of doing things. And I certainly think that's really true for healthcare. I hope that we look at some of these regulatory burdens that have been removed and put that in the context of the information blocking effort and telehealth and emerging technologies and emerging models of care and reimbursement, and say to ourselves, let's, rather than just flipping the switch and going back, how do we think about sort of what a new normal looks like for healthcare?
So if you could kind of take your magic wand and get rid of, you know, one or two, a couple of regulations that would really help connect the healthcare world, you know, what do you think those would be?
You know, I think it's hard to say. I'm certainly not the privacy legal expert,
Yeah.
but I do think that HIPAA is quite often misunderstood and
Yeah.
over-enforced by individual providers or hospitals that don't understand, or you know, take an
Sure.
overly aggressive approach to protecting healthcare data in situations where it could probably flow a little more freely. I also think the business incentives are a significant barrier. So I think that some of this will sort itself out in the market, because I think that as you have folks who have more exposure to technology and more comfort using technology in all kinds of ways in their lives, they're going to start to demand that from their healthcare system. And they're going to start to say to their provider, why can't I get this online? Why can't I? I think you're starting to see some of that. I think the information blocking rule will absolutely help with that. But I really think, you know, I'm a policy person, so I'm probably biased, but I think the government is going to have to wade into this very carefully, right? There are very real public policy concerns about protecting privacy and security. But I think there's also an equally important public policy goal of making our healthcare system really an ecosystem that's much more connected, and where patients' care is delivered in a more sort of comprehensive way, and thought of in a more comprehensive way, rather than a visit by visit, location by location kind of model.
Okay, now the most important question. What are you most looking forward to when you get out of quarantine or you get out of your house?
I would have said a haircut, but I got my kids to give me a haircut, which actually came out all right. So I'm pretty happy. I would have said a haircut. No, I don't know. You know, post quarantine, I feel like I'm chipping away at my to-do lists.
Really?
Well. You know, when you're stuck at home, you wind up getting a lot of those little things that you've neglected for a long time done. So
yeah,
maybe go to the beach probably would be the thing I would say. You know, we're big beach goers, so it's not the same when you can wander onto the beach, look at the beautiful beach and the sunset, and then have to leave because you can't throw your blanket down. So I think that's something I'm looking forward to.
Well, I hope you get there.
And getting my kids out of the house.
Well, you've got a fourth grader, we heard. So
yes, exactly. A fourth grader and a first grader. So they are
probably got to get back to those multiplication tables. So.
That's right. And there's only so many TikTok videos that can be watched.
Well, I really appreciate you joining us today. This has been a great conversation. I hope you come back, and thank you.
Yeah, I really enjoyed it. Thanks so much for having me.
All right, great. All right, everybody. We'll have a copy of this online later today. So thanks for joining us, and we'll see you next week.
Thanks, Jen.
All right, bye.